and Dr. Julie Dargis from Core Group. And I will turn it over right now to Dr. Sarah Paige, our Global Health Security Advisor, and she will introduce all of our wonderful speakers and get us started. So thank you for joining us. Please start as we progress. Make sure you can put your questions in the chat box. And I'm losing my voice, so thank you very much. And I'm going to turn it over to you, Sarah. Over to you.
Great. Thank you, Lisa. Thanks for spending the remainder of your voice with us this morning. Welcome, everyone. We have a very rapidly growing list of participants joining today. We're going into our third month of holding core group COVID coordination calls, and these have been really productive in building networks and strengthening relationships and cross-sector, cross-country learning. So I'm really honored to be a moderator today. My name is Sarah Paige. I'm the Global Health Security Advisor with Core Group and supporting Core Group Polio Project. I want to say Happy Workers' Day to everyone. I know this is a holiday in many parts of the world and a very well-deserved one. I want to also thank Julie and David, Avani and Lisa for regularly holding these COVID coordination calls. They're very powerful and very appreciated. Also, Lydia Bologna from CGPP and Aaron Fry from PATH shared some insights on the polio immunization and nutrition themes right now to help me get up to speed as a really well-informed moderator. And the purpose of today's call is to discuss these two essential services that are part of the normative health service delivery function and are considered sentinels for when a health system may be in crisis. When immunization becomes spotty, becomes postponed, falls short of achieving its goals, when malnutrition spikes, when we see food insecurity sort of exploding, then we know that not just the health system is in crisis, but value chains, supply chain, logistics. These are indicators of not just an outbreak itself, but also the knock-on effects of an outbreak. They're intertwined and they're signals. What we want to learn about today is that precisely because of the importance and sort of the high visibility of immunization and nutrition, there are opportunities to leverage that visibility in those infrastructures to do COVID delivery and to work hard to maintain service delivery, the normative service delivery functions that everyone needs. Without immunization, without nutrition, then those who are most vulnerable experience knock-on effects for generations, like a cascade of effects. So they're really important to sort of keep our eyes focused on our normative healthcare service delivery mechanisms as well as responding to the crisis. So we're really fortunate today to have a powerhouse of panelists, starting off with Ms. Anuradha Gupta. She's the GAVI Deputy CEO. She's on the line with us today. She's been with She's been with GAVI since 2015. I know it wasn't 5 years. She's driven efforts to create new models of country-level alliance support through the establishment of partners engagement framework. She's helped to improve country ownership and leadership of Gavi-supported programs while enhancing accountability. In 2019, Gavi received the prestigious Lasker Bloomberg Service Award for providing sustained access to childhood vaccine in the world's poorest countries. And prior to Gavi, Anuradha served as the mission director for the National Health Mission of India, where she ran a very large and very complex public health program. She's a passionate, influential advocate of women, young girls, and children's health, and Anuradha played a leading role in India's efforts to eradicate polio transmission, reduce maternal and child mortality, and revitalize primary health care. Anuradha holds an MBA from the University of Wollongong in Australia and received executive education from John F. Kennedy School of Government at Harvard, Stanford Graduate School of Business, and Maxwell School of Citizenship and Public Affairs. So she brings a really well-rounded, very grounded systems thinking, leadership approach to Gavi. And with that, the process will be, we'll hear from Anuradha first and have a brief discussion, and then we'll move into our other panelists, and I will introduce our other panelists at that time.
Thank you, Sarah. And can you hear me?
Yes.
So good morning, everybody. I'm in San Francisco, but I'm sure people are joining from all parts of the world. So good morning, good afternoon, good evening, depending on where you're joining from. And thank you, Lisa, and thank you, Core, for organizing these wonderful interactions in these very difficult and trying times, and giving me an opportunity to shine some light on how immunization is playing out in this very challenging context. So first of all, David, can you move to the first slide, please? Yeah. So if you sort of have a look at those 73 lowest income countries that Gavi supports, and they are across continents in Asia and Africa, Europe, South America, you would see that fortunately these countries currently have a very relatively a lower number of COVID infections and deaths, accounting for about 2% of global COVID-19 cases and deaths. 6 out of our 73 countries actually are not yet reporting COVID infections. So we have about 85,000 cases and about 3,000 deaths in these 67 countries. And over half of these cases and deaths are in 3 large Asian countries, including India, Pakistan, and Indonesia. So what we are seeing here in Gavi-supported country is a slower spread of the disease, and also high variability across a continent, across countries, but also within countries. I can see that colleagues have joined from several Gavi-supported countries. Some of our partners on the ground are also on this call, and I'm sure they would confirm that if you really start to unpack numbers for individual countries, you find that whatever cases we see there also are concentrated or clustered in some parts of the country. So huge variability. We of course have 22 countries that are in complete lockdown, which really means that physical distancing or social distancing measures are in place, and of course they have a huge impact on provision and uptake of services. Next, David. Next slide, please. Hello. David, could you move to the next slide, please? David, can you hear me? Hello?
Yes, sorry.
Yes. So what we are seeing here is, so as I said, in a way, it's a good thing that we have fewer cases reported from Gavi countries. We don't know yet what the reasons are. It could be, environmental, biological, demographic reasons. It could also be reporting issue. It could be testing issue. But I do think that though it may be hard for us to understand the exact number of cases in countries, data around death is probably a good marker. And it's difficult to hide an abnormal increase in the number of deaths, particularly in communities. And to me, therefore, the role of CSOs is vitally important in stepping up community-based monitoring of any kind of unusual trends with regard to mortality that might be seen across countries. So while Gavi countries really have a bit of a time to prepare for this pandemic, we are already seeing a devastating impact on immunization programs. So we had about sort of 50 large-scale campaigns lined up and 14 new vaccine introductions, largely of typhoid and rota vaccine. And we see that all of them, 50 of them, have been delayed or suspended. And these campaigns largely relate to polio and measles rubella. So really high risk now of measles outbreaks, because in many of these countries, community immunity gaps are extremely high, and we are already seeing in a few countries ongoing measles outbreaks. Typhoid, rota, as I said, introductions have been put on hold, and that would likely have an impact on the breadth of protection that all of us have been striving to promote in Gavi countries. Now, as I said, there are about 22 countries that have officially imposed lockdown measures, and though through a survey that we sort of co-conducted with WHO, we found that most of the countries are claiming to maintain fixed site immunization services. In reality, the uptake of immunization has been severely hit, and that is because of a couple of reasons that all of you would be already aware of. And what we are seeing here is that it is difficult for caregivers to come to facilities because of fears, but also because of transport disruptions. We are also seeing low availability of health workforce, partly because health workforce has been redeployed, but also because, again, health workforce currently does not have protective equipment and tools, and therefore there are heightened fears and misgivings on the part of health workforce. We have seen that about 50% of Gavi-supported countries have partially or completely suspended outreach services, which really means that the most marginalized or vulnerable populations or populations living in remote areas are clearly now not benefiting from provision of immunization services. We've also seen global disruption of global of vaccine supply chain. UNICEF had difficulty shipping vaccines to countries because, as you know, our vaccines come, for example, from Serum Institute of India, and because of lockdown measures in India, it was very difficult to maintain supplies of vaccines. So we've seen that about 18 countries are at risk of vaccine stockouts because of global disruptions, but also because of transport disruptions within countries. Next, please. So what is our response to this very challenging situation? So I would actually bifurcate Gavi's response into two categories. Our first concern was to roll up our sleeves and actually step up to provide the requisite flexibility to countries to reprogram existing Gavi support to get prepared to respond to COVID challenge. And immediately we allowed countries to reallocate up to 10% of our health system strengthening support, our technical support that we provide to them on ground through a variety of partners, and many of you are represented on this call. And in the case of those countries that have already transitioned out of Gavi support, we have, of course, continued engagement. So we brought in flexibilities for countries to avail of. Within the Secretariat, we made a commitment that we would approve all these reallocation and reprogramming requests within 5 days, and we have tried to stick to that timeline. Our key strategy here is to actually stand behind the country strategic preparedness and response plan and to coordinate with other funders. You are all aware that World Bank is a big financier now in this context. And of course, there is Global Fund, and there are several other agencies that have their own bilateral aid programs. So really making sure that we work in a coordinated manner and try to support the country in a very systematic fashion for the right things that they would need in order to grapple with this pandemic. The second now focus in parallel for us is to make sure that routine immunization services are maintained. So what we are trying to do is to actually dialogue with countries to make sure that countries' strategic preparedness and response plans reflect due focus on maintaining essential health services, of which, of course, immunization is an important one. We are increasingly now advocating how disruption of immunization services would lead to collateral damage and double whammy, because if children do not receive immunization, we would see large-scale VPD outbreaks. In fact, we are already seeing that in many cases. For example, in Ethiopia, as I speak, there is a yellow fever outbreak 200 kilometers away from the national capital, which has already claimed lives. In DRC, Ebola has again come back. Again, there have been some deaths. They are also fighting an ongoing measles outbreak. In Ghana, there is a meningitis outbreak. In Niger, and this is really latest news, we have a polio outbreak. And in Yemen, there is a cholera and there is watery diarrhea. So a lot of countries where we see disruption of routine immunization are already starting to see the beginning of VPD outbreaks. So really making sure that countries are able to quickly resume or reestablish immunization services. With WHO, we have worked to put together guidance on how to reorganize service delivery in this context, observing social distancing measures. And we are really looking to our CSO partners to make sure that countries are supported in reorganizing services so that there is greater trust on the part of community, but the health workers also are sort of more reassured and find themselves equipped to deliver services. Now, the third, we also stay aware of the fact that once the acute phase of this pandemic is over, we would need to work with countries for rapid intensification of routine immunization, including catch-up strategies and overall system strengthening. Another, of course, a very important part of our response is to engage very heavily and closely with the development and rollout of COVID-19 vaccine. So our biggest concern has been to make sure that there is equitable availability, distribution, and delivery of this vaccine in lowest income countries. And therefore, we are engaging with the whole sort of global community. You have already heard about ACT access to COVID-19 tools under WHO's auspices, where we are leading on the vaccine pillar. So there are three pillars: therapeutics, drugs, and vaccines. And with CEPI, we are co-leading the vaccine pillar to make sure that timely steps are taken in order to ensure that there is manufacturing at scale of the right products and they are made available to countries who really need them the most, and those populations who within those countries who really need them the most. One of the things that I would want to highlight is the urgent need for, and the imperative actually, for coordinating very closely with an array of partners at the global level and at the country level. And we have therefore stepped up our coordination with alliance partners and with the view to leveraging not just WHO, UNICEF, and World Bank, who are our sort of founding members and core partners, but also many of our expanded partners, and I can see that some of them are represented here, and particularly CSO platforms. We are also now regularly in touch with the health ministers of countries and have set up a mechanism where there is a personal conversation to understand how things are moving on the ground, what are the issues that the country leadership is facing, and how can we be flexible and agile to support countries. Next slide, please. You can see here that the reprogrammed funding has been used by countries to procure PPE and infection prevention and control, risk and behavior communication, surveillance and diagnostics, and case management. So a large part, 44%, is for PPE and IPC. But I would really want to highlight one thing. We are seeing here an issue of procurement. So it's more than financing. Financing is now available, but procurement is proving to be a huge challenge in these countries, because you might be aware there is overwhelming dependence on just a couple of countries for PPE, whether it is masks or other equipment, and their trade barriers and protectionist measures have been put in place by several countries, making it very hard for these equipments and stuff to travel to countries where there is an urgent need. So I think CSO's voice will be extremely important to raise awareness around this issue, that countries have to lower trade barriers and not resort to protectionist measures, because it is going to really exacerbate the existing challenge. Next slide, please. So what are the implications for our next strategy? I would just want to explain that Gavi has 5-year strategic period. So our fourth strategic cycle finishes this year. 2020 is the last year, and 21 onwards, we are embarking on a new strategy. And really the central aspiration of this new strategy was to leave no one behind. And we are actually bringing
Thanks for your patience, everyone. It looks like we have a...
might be suffering from a multitude of vulnerabilities. So really, so far, how does this pandemic impact our priorities? The first one is introducing and scaling up vaccines. I think that would be a challenge. We are not expecting countries to be in a position to continue to introduce new vaccines. So we will probably see a pause there, and our focus would really be on restoring immunization coverage of vaccines that already exist in national immunization programs, really stepping up surveillance and making sure there is efficient access to stockpiles for VPD outbreaks, and then, of course, rollout of future COVID-19 vaccine. On health systems goal, we are going to stay very focused on equity, because we know that this pandemic has hit the most marginalized, vulnerable, and poor populations the most, and therefore focus on zero dose is going to become even more important. We stay aware of the fact that we will have to promote differentiated, targeted, tailored approaches, subnational level, and also make room for a lot of creative local solutions, and therefore the involvement of local partners, communities, is going to become key to success here. Our third goal is always on sustainability. We encourage country ownership and domestic budgeting for immunization, and we have really succeeded extremely well. Many countries have transitioned out of Gavi support successfully, but here we will need to introduce a lot of flexibilities with regard to eligibility, transition, and co-financing, given the economic meltdown that is bound to happen in all Gavi-supported countries with their fiscal space shrinking. And the last one is our focus on healthy markets. Here, of course, we will continue to work to create healthy markets for the existing antigens that we support, but our focus will be on uninterrupted supply during pandemic, and of course then COVID-19 vaccine is going to become a very, very important priority. And the last slide, David, if I could request you, is a plea that to do all this, Gavi would need resources. We have, David, could you go to the last slide, please? And we have put out an ask of at least $7.4 billion. So our replenishment, the final replenishment event is on 4th June, as you might be aware, hosted by UK. It will be a virtual event, and we are hoping that we would be replenished. We would get to at least $7.4 billion, but we would need more resources in order to really make sure that we are able to weigh in for recovery of health systems, for resumption of immunization services, and really to reach those children who need immunization the most. And we would, of course, for COVID-19 vaccine require supplementary resourcing because this $7.4 billion ask is just to maintain and take forward our existing core work. And of course, if COVID-19 vaccine has to be rolled out in countries and has to be delivered efficiently, and we are not yet clear what kind of target population we would be looking at and what kind of delivery strategies would make sense, it would all require additional funding. And that is where the voice of CSO is going to be extremely, extremely important. So really making a request to all of you to advocate for replenishing Gavi. Over.
Thank you very much, Anuradha, for that really interesting and informative presentation. We've already gotten requests for your slides to share after this. So at this point, we have some time for questions and answers. And we'll take about 5 minutes for that. And we have a number of powerful questions in the chat box. I think in terms of sort of building on this question about the replenishment, can you speak a little bit about the importance of all countries committing to that, what that implies?
Yeah, so I think that, of course, for replenishment, all countries are going to be important. So first is the countries, donor countries. And as economies are taking a hit, it will be extremely important that replenishing Gavi is prioritized. And then, of course, there are countries who receive support from Gavi. And of course, we'll continue to advocate for greater country ownership and a continued domestic financing for immunization. But I'm sure that there are some countries at least who are going to struggle with it, particularly those economies which are dependent on commodities as the primary source of their revenue.
Thank you for that. We have another question from Nefra. Does Gavi support for PPE include supporting local PPE production, including by facilitating local manufacturers who may not have manufactured PPE before to shift their facilities? And if so, can you kindly share any specific country examples?
So I would want to clarify that our support to countries is modest. So typically we invest about $1.3 billion in health system strengthening support in countries, over a period of 5 years. So at this point of time, when we provided flexibilities to reprogram Gavi's health system strengthening support, it comes to about $200 million. So $200 million spread over 73 countries. And really the idea here is to support countries to put in place certain urgent measures on PPE and infection control and prevention. So manufacturing of PPE is, a long haul. It's an effort which is going to be capital intensive, and that's not what Gavi's resources are meant for.
Thank you for that response. And now over to a technical question. We have one question about if Gavi has tailored strategies to ensure that vaccines get to health facilities in rural locations where healthcare is fragile and demand generation is affected. Do you have examples you can share for that?
Yeah, so I think what we are trying to do is to sort of, so this is a new concept. This we introduced about 5 years ago when we started to talk about differentiated approaches. And because before that, typically from the global level, all countries would be treated alike because, there is this whole notion of treating all countries equally. But then during the last few years, we've started to recognize that countries would have their own context, very unique context, and therefore we need to differentiate. And then saying, okay, within countries there are some national contexts and communities that require very tailored approaches. So one example that I can immediately give you is of Laos, right? In Laos, we have these ethnic minorities, ex-Hmongs, and their idiom is different, their language is different, and the use of that language, their language actually is prohibited under the national law. And therefore, embarking on some very creative communication strategies, to maintain and promote demand for immunization and other services is something that we have focused on a lot. And Chad is another country where we have one province called Bata, where you have nomadic populations, and the immunization coverage rate is 2%. So also North Nigeria, where we have certain areas where immunization rates are extremely low, and also community trust in public provision of services is low. So these are some of the contexts where we have partnered with CSOs and other community-based organizations to make sure that they have highly tailored and locally suited strategies to spur demand. One of the very interesting things that came to my attention today was this whole gender dimension in PPE, right? Where it seems that the entire PPE is designed for use by male workers, and it's heavy and it is hard to wear, but if it is also oversized and is not suited to the needs of a female health workforce, and we largely have females, in health workforce, then gender dimension has not been clearly paid due attention. So these are some of the things that we have started to now build awareness about.
Great. Thank you very much for that thoughtful response. We will pause your response to questions now and invite the Gavi team to continue responding to questions in the chat box and have guests continue to put your questions in the chat box. And we've had really robust conversations that way. And Anuradha, do you have any final comments that you'd like to share at this point?
So my biggest worry is that in this whole focus on pandemic, we should not allow double whammy or collateral damage, and that it is going to be extremely important for all of us to make sure that we contain the knock-on impact of this pandemic. Otherwise, we will see much more mortality or much higher mortality from other diseases.
Come on, hon.
And one of the
Dad and I need you to dig
one
deep.
of the analyses that we have just gotten done through London School of Hygiene and Tropical Medicine shows that for every COVID-related death as a result of exposure to immunization services, you are actually preventing lives of 128 children by sustaining routine immunization. So I'm sure you would have similar kind of studies on nutrition and several other essential health services. So I just do feel it is important for us to continue to advocate for continued attention to essential life-saving health interventions. And the second point I would want to make is this is the time for us to collaborate and really push for integrated service delivery. And I'm talking about health interventions within health, but also health enhancing. So really nutrition, immunization, awareness about sanitation, water, deworming, several other kinds of supplementation that is required at community level. All these services have to come together with sharpest focus on marginalized, vulnerable populations, because they are the ones that who are going to become the epicenters of disease and would not have the financial bandwidth to protect themselves. So you would see disproportionate amount of mortality, morbidity concentrated in poorer households. So really my plea to CSOs, because you are the ones who are going to advocate and stir the governments and all other actors into the right kind of actions. Over.
Thank you for those powerful words and the call for collaboration and working across sectors. I think we all feel that and are really striving to do a good job of that type of collaboration that goes beyond a webinar and really goes deep into relationships. Okay, so with that, Ms. Anuradha has to step away soon, but the GAVI team will continue to answer questions in the chat box. And we will go ahead and pop over to the rest of our panel of presenters who will be providing some very grounded experiences from their work. First up, we have Rosana Oliveira Macedo, Head of Nutrition at the Federal Hospital. My chat box is blocking it. Hospital Federal dos Servidores del Estado at Rio de Janeiro and partner of Smile Training. And she will discuss telehealth nutrition counseling, supporting mothers of children with cleft palate. And Camila will translate and assist in that presentation. Following Rosana and Camila will be Rebecca Fields, Senior Technical Advisor with Immunizations with JSI. And she'll present learning on the ground of the effects of immunization in countries where JSI works and serves as a resource to ministries and communities on policies and guidance. And then finally, we'll have Dr. Usman. He's the Secretariat Director, Chief of Party, Country Manager of Core Group Partners Project in Nigeria. He'll share insights onto the integrated nature of coordinating country-level response to COVID-19, including creative solutions to support immunization campaigns during COVID-19. So we had our poll, and we'll share some of the results of those a little bit later. And want to go ahead and get started with Rosana and Camila with our first presentation. Please continue to pop your questions into the chat box, and please remember to mute if you're not speaking. With that, we'll turn it over to Spencer.
Hi, good morning. First, I want to congratulate Core Group for this initiative, and thank you for this opportunity. My name is Camila Beni. I'm the Program Manager of Smile Chain here in Brazil. Smile Chain is an international charity with a sustainable approach to a solvable problem, cleft and palate. We empower local medical professionals to provide free cleft surgery and comprehensive care in their communities, their hospitals, our partners. During this pandemic, we have created a telecare program here in Brazil to assist our partners so they can continue to treat their patients remotely. Many partners are participating with us on this, but I wanted to focus today on a partner based in Rio de Janeiro, APAC. I have here with me, as mentioned before, nutritionist Rosana Macedo, who will be talking about the importance of nutrition program for cleft patients and the challenges she's been facing during this time. Rosana is working in this field for 28 years, and she's responsible for the nutritional development of the class patients. Nutrition program is key for class patients since they face many feeding problems. So when her center was closed due to the pandemic, and knowing the impact that this would have on her patients, she knew she needed to act fast. She quickly found a way to connect and keep track of her patients, WhatsApp and Facebook video calls. For the new patients, they first contact with her social worker of the center, who then pass Rosana's contact info, and then they reach out to her. Since the quarantine started a little bit over a month ago, she has been available 24/7 through her own personal cell phone, Facebook, WhatsApp, Skype, in any way necessary. She also has been performing scheduled consultations to keep track on her patients and also see how the mothers are doing. Also, she has been having regular meetings with the other professionals of her class team, the class surgeons, the speech therapists, the psychologists, the social workers, etc. On those meetings, they have been talking about the patients they've been seeing during this time, how they're doing, their development, and making sure they are okay. She also has been making videos for Smile Train to answer questions that parents are making for us on our social media. Everyone, please welcome Rosana Vasquez.
Hi, good morning. Cleft patients face many difficulties with nutrition because they get tired easily while being breastfeeding. The stomach can fill with air, and the babies can have any difficulty to gain weight. Besides, ingested milk can get out through the nose cavity, among others. It's very important to accompany them closely because it can be a very challenging time to mothers, especially at the beginning. Cleft babies have more difficulty to gain weight and to be well nourished, which not only can interfere on their development, but also their cleft treatment. So during these calls, I try to do a consultation that we do at the center because my main concern is that patients won't have any nutritional complications. A few days before, I asked the parents to send me the general info of the child since I have the cards with me. So asking for information regarding their growth, development curve, feeding behavior, if it's breastfeeding or not, for example. With this information, I meet them. On the consultation, talk about current weight situation of patient. If necessary, I make adjustments to the nutrition program for this patient and explain why. I answer questions and then schedule the next meeting. After I write all the orientations that I gave them through WhatsApp to make sure that the parents will keep all the information that I have said. I also use this time to provide emotional support to them. It's very, very important. As you can see, due to these online consultations, I have to be creative in order to find solutions and teach mothers on how to measure the development of the children. For example, to see the weight. If they have a scheduled appointment at the health clinic, I recommended them to weight their babies on this occasion if possible. If don't have appointment there, I recommend the mother to weight herself holding the baby, as you can see on the picture above. Many don't have a portable scale at home. On those cases, I teach them to measure the arm of circumferences during the online consultations with me or with illustrations, as you can see above. Although I won't be able to know the weight of baby and the arm circumferences get bigger, it will mean that the patient is gaining weight. To assist cleft patients and parents with telecare during the pandemic time is crucial, because doing that we can monitor the patient's growth and calm parents, showing them they are not alone during this challenging time. I want to finish this presentation by showing a patient of mine. This is Luis Henrique. Yes, it's baby. It's his baby. When he first came to me, I have been accompanying him nutrition development. Here is him again with the yellow shirt a few weeks back, and below is him again with his parents. And here's what his mother told me this week. Gratitude, that's the word to describe everything that has been done for my cleft baby, or better yet, for our whole family, even in the moment of a pandemic. Thank you.
Thank you very much for that really informative and powerful description of the work that you're doing, moving from accompanying patients in person to providing telehealth support. And that you've been able to be successful is remarkable. We have time for questions. Just a couple questions at this point. I have one in terms of, no questions. Okay, so let's go ahead and move on to the next presenter, please, and we'll do questions at the very end. Thank you very much.
Thank you very much. This is Rebecca Fields. I'm a Senior Technical Advisor with John Snow Incorporated. JSI is a public health consulting firm that has been working very actively in immunization for more than 30 years in global technical leadership projects, as well as having a strong presence on the ground in over 55 countries over the past many years. And at the present, we have an on-the-ground presence in about 15 countries. And what we have been doing just in the past few weeks now is to set up a structured process for really learning what is going on the ground with immunization in the countries where we work. We have discussions on about a weekly basis. We capture that information systematically, and we also use that information in the various global and regional level working groups that we take part in. As Anuradha Gupta mentioned, it is really critical to have strong coordination among all the partners, especially including the CSOs, of course. I just wanted to step back for a moment and give a little bit of background on some of the guiding principles from WHO, which has been taking a very assertive leadership role together with UNICEF and Gavi on guiding principles for immunization in the context of COVID-19. Back about a month ago, WHO put out some guiding principles. A link for them is shared in this presentation. And just very briefly, at sort of a high level, these are as follows. Number one, as Anuradha already mentioned, immunization is a core health service that really needs to be prioritized and safeguarded for continuity. Number two, VPD, that is to say vaccine preventable disease surveillance, is essential to maintain and actually reinforce in conjunction with efforts for surveillance for COVID-19. And that's because at this time, it's more important than ever to see where are these vaccine preventable diseases diseases starting to pop up again? Where are we starting to see measles outbreaks or outbreaks of other diseases that vaccines can prevent if they're given? But if they are not being given, if vaccination services are being interrupted, then there is a greater risk that they will be coming back. And that's why we really want to make sure that that surveillance is strong. Number 3, if immunization services are negatively impacted, then countries will need to have catch-up vaccination campaigns in the post-COVID-19 crisis period. Whatever that period looks like, we don't know when that will be exactly. And certainly there has been discussion that such catch-up campaigns would not necessarily be restricted to immunization, but would also take into account other interrupted services. Number 4, at this point, mass vaccination campaigns should be temporarily suspended, and Anuradha spoke to that as well, that many such campaigns are being suspended. But number 5, there is an exception to this, perhaps, and that is that in the situations where there are outbreaks of disease going on, such as major measles outbreaks, case-by-case analysis of the risks and the benefits of organizing a campaign to contain and respond to such outbreaks needs to be carried out. And again, it may vary across countries and even within countries, as Anuradha mentioned. WHO is in the process of developing guidance on this very topic. About when and where campaigns could or could not be carried out, and what circumstances would need to be in place, and what safety measures and precautions would be needed. And on the right-hand side of this slide here, you can see just a few of the guidance documents that WHO and UNICEF have been putting out. There are quite a number of documents. There will be more. And actually, in the interests of not overwhelming countries with too many documents, WHO and UNICEF have partnered up so that they're issuing documents jointly. And the one in the middle that you'll see is a new one that I don't think has been widely distributed just yet. It is operational guidelines for national immunization programs in the WHO Africa region for immunization in the context of COVID-19. So what I'm showing here is just kind of a way for us to think about how to find and address vulnerable points for immunization in the context of COVID-19. And probably this little schematic is not unique just to immunization. So looking on the left-hand side at the 3 overlapping circles here, the Venn diagram, we see that you have to have human resources. You have to have a functioning supply chain that actually gets the vaccines out to the service delivery points. You need to have both of them in order to actually provide services. But affecting all 3 of those areas is the need for very clear, consistent communication and also community engagement, so that those services are actually used. And informing all 3 of those areas, as well as the communication and the community engagement, is the need for data. And we know that the situation is rapidly changing with regard to COVID-19. And so we know that data is going to be updated on a regular basis. And one of our challenges is to make sure that it feeds into and informs the communication, the situation with human resources, supply chain, and service delivery, so that there can be continued provision and also utilization of immunization services so that communities can be protected. So with that in mind, we can sort of take a look at where are those vulnerable spots. Now, so some of our learning is emerging learning is taking place at, is being amassed at global and regional levels, but it's coming really from the countries themselves. Some of the information I'm showing here is both from our experiences at JSI, but supplemented by information from the WHO Pulse Survey that Anuradha mentioned, as well as Gavi situation reports and other informal learning that we have. And this is really changing on a day-by-day basis. These slides, I put these together a day or so ago, and already some things have changed. So Anuradha mentioned already that there are lockdowns in 23 Gavi-eligible countries and concerns about declining uptake of service and coverage. WHO's Pulse survey has shown that immunization services have been suspended, disrupted, or possibly disrupted in over 65 countries, but these data are incomplete, and more information is needed on a regular basis. As Anuradha mentioned, outreach services have been cut in many places out of concerns for safety, particularly to the ability to ensure that safety measures and precautions can be taken during outreach services. Well, that's really a big challenge. Frequent hand washing, use of personal protective equipment, that is much more difficult to do during outreach services than at fixed sites, at fixed health facilities. And that's why we're seeing a shift towards maintenance of services provided through fixed services at clinics. We're also seeing logistical obstacles because transport is being diverted for other purposes. I won't go over some of these next points that Anuradha had already mentioned. Just looking at the bottom bullet here, while it's too early to broadly assess the impact on immunization coverage, we are seeing emerging evidence that suggests big impact in some places, smaller impact in other places, and again, the kind of variation across and within countries that Anuradha mentioned. However, in Sindh province in Pakistan, a 65% drop in immunization coverage was measured immediately after the lockdown was introduced. We are starting to see that there's a more pronounced impact in urban areas than rural areas, at least at this point in time. So, for example, we haven't seen a real effect on routine immunization in rural Tanzania, where there's no lockdown. Similarly, we're hearing from our staff in countries that, for example, in Niger, there's no real impact on the provision of the routine immunization services, except that it is now more difficult to move out and distribute vaccines to those rural sites. For example, new measures have been put in place whereby health personnel have to get official permission from local mayors to be able to travel and distribute vaccines. Now, so far, there has been no problem with getting that kind of approval for local movement, but it is another step that has to be introduced. But I guess the real point to make here is that the data are far from complete at this point. Active monitoring is needed to understand where, when, and why services are being interrupted. And as Sarah mentioned at the outset, if services are being interrupted for immunization and for nutrition, they're probably being interrupted for other health interventions as well. Okay, a few more things about the emerging effects that we're seeing. Again, we're seeing supply chain interruptions. We're seeing that the supply chain interruptions with vaccines are occurring at a couple of levels. One is from the site of vaccine manufacture to the national warehouses due to interruptions in national flights, international flights. There are fewer flights taking place now. And so there's less capacity for transporting vaccines. We're also seeing stockouts at facilities due to internal transport problems, what with transportation being diverted for other purposes related to COVID-19. The use of personal protective equipment, we are hearing that that is variable. And that is partly due to availability of supplies, but it's also partly due to acceptability. For example, our staff are telling us that in some parts of rural Ethiopia, health workers are reluctant to make use of face masks because it introduces a barrier, a perception of a barrier. And health workers are concerned that it gives rise to mistrust with the clients that they are trying to serve. So this is something that we need to be looking out for on a very active basis and figuring out what can we do to enable the correct use of personal protective equipment. We are also hearing about adjustments to service delivery that are being introduced in some places. And while this poses some challenges, it may also pose some opportunities for improving immunization services over the long term. So, for example, we're seeing some basic social distancing measures being introduced. And in this photo on the right here, you can see this is again rural Ethiopia, where a social distancing measure has been put in place. This is at a rural health post. Just to try to keep caregivers and their children distanced from each other. We're seeing extended hours of services in an effort to try to space out how many people show up at the health facility at a given time. And we're seeing more frequent sessions in some places being introduced, again, with the goal of reducing the number of clients and per session. We're also seeing some increased use of interpersonal communication by way of phone calls and SMS texting with mothers to set up appointments. These are all some measures that over time may actually serve to improve routine immunization services in the future. Immunization staff at national level, by and large, are not being pulled off of their regular duties for immunization because immunization is considered an essential service and needs to be protected. However, their attention is being diverted from normal system strengthening activities in order to accommodate some of the new needs that are coming up with COVID-19. With regard to communication, we're seeing that at this point it is still relatively limited. It's been, some of the attention has been put on detecting rumors and misinformation and trying to contain them. Certain measures from place to place on, as I mentioned before, setting up SMS texting for appointments. But really there's much, much more work that needs to be done in this area to get out ahead of the issue and try to reconcile some of the messages right now that are somewhat at odds with each other. So, the big message going out, particularly in urban areas, is that, you're supposed to stay at home. There are lockdown measures in place. So how does that play out with messages that say that it's important to get your child vaccinated? Going for a preventive service like immunization at the same time that you're hearing messages about the need to stay at home for safety reasons poses some real challenges. And much more work is going to need to be done for strategic community engagement at this level. And then another point that we're hearing is that there are variable levels of credibility in the pandemic at all and the dangers that it presents. This is especially the case in rural areas where very few cases have been reported to date and where it seems like the measures that are being put in place are sort of disproportionate to the actual risks. So this is something where, again, we need to be listening very carefully. We need to be getting out ahead of the problems before they come up. And just with regard to that, I wanted to point out some of what JSI has been doing in India with strategic communication. In India, JSI manages the Immunization Technical Support Unit, the ITSU, which provides immunization guidance and strategic communication support to the Universal Immunization Program and the Ministry of Health and Family Welfare. And the points that you see here are just a few of the many, many things that the Immunization Technical Support Unit has been doing. It's been helping to develop the community and social media engagement strategy for COVID-19, and very important, disseminating that information. Disseminating social media key messages and graphics on COVID-19 through Twitter and other social media. Steering the development of videos on Corona warriors to get better recognition of the important role that health workers are playing. Developing action plans for states to generate awareness generation on COVID-19 for persons with disabilities. Developing an advisory to address stigma towards COVID-19 among health workers and patients and their families. last slide here are some resources. Sorry about the title on this. I'm not sure why it looks that way. But before going on to these resources, as Anuradha was talking and thinking about some of the things in the chat box here, what's really come out to me is thinking about the many important roles that CSOs can play. CSOs, and this is with regard to immunization, but nutrition and other primary healthcare services as well. CSOs are clearly critical players in strengthening engagement with the health system, so as to make sure that there is clear communication, that there is trust maintained in the health system, that there is strong resilience based on that trust in the health system to help contain rumors and misinformation, to encourage the use of immunization services where there is, again, misunderstanding about whether caregivers should be taking their children to vaccination or not. CSOs have an important role to play with local problem solving to help deal with some of the new challenges that are coming up in the context of COVID-19. CSOs have a great role to play in capturing and sharing some of the learning that is coming out with context-specific solutions and with some problems that may be popping up as well. A last point I would just mention is that CSOs have a vital role to play in detecting and reporting where services are being interrupted. Where and when is that happening? Which communities are most disadvantaged by disruptions in services? And reporting that upward and onward with both health officials and other local non-health actors. So with that, I'll stop and just mention that there are a number of high-quality resources, trusted resources that are shown here. Thank you.
Fantastic. Thank you very much for that really thorough and really interesting presentation. In the interest of time, we're going to go ahead and hop over to hear from Dr. Usman, the Secretariat Director for Core Group Partners Project in Nigeria. And he'll have about 8 minutes for speaking, and then we'll jump into the questions. Thank you so much.
Thank you very much, Sarah. Thank you for this opportunity to share our experience in Nigeria with COVID and how we've been working. I'm going to start by referring to some of the points that that Mrs. Fields made regarding the role of CSOs in the fight against COVID. In Nigeria, we are funded by USAID Core Group Partners Project to support polio eradication initiative in 5 of the 11 polio high-risk countries in Nigeria. And due to COVID, we've had to do a lot of reprogramming. And in order to succeed, we do a lot of work, a lot of leveraging of existing resources, a lot of work with partners, as well as with the stakeholders at the community level. Just to give a bit of a background, Nigeria, like you know, is one of the Gavi-eligible countries. We are, of course, a population of over 200 million. And you can imagine the impact on our health system with the arrival of COVID. The first case of COVID was reported on 27 February this year, an Italian who lives in Nigeria and came in on 24th and had symptoms. He was isolated, and through him, COVID came into our country. Currently, we have a total of 1,728 confirmed cases of COVID, with 307 discharged, as well as 51 deaths. Our country has 36 states and the Federal Capital Territory. 34 of the 36 states currently have COVID, and you can imagine its impact on our health system. The target has been to conduct 3,000 tests daily, but unfortunately, that has been unattainable due to severe health system challenges. And so, what are we doing? Core Group Partners Project is, of course, partnering with 3 INGOs, services, Save the Children, and International Medical Corps to provide polio eradication services community level by raising awareness of the importance of polio. But unfortunately, what we've done is we've had to integrate the work we do in terms of polio eradication with COVID. And what did we do? Like Phil was talking about, campaigns have stopped, polio campaigns have stopped in Nigeria because all attention is now on COVID. And because polio campaigns have stopped and all attention is now on COVID, the polio campaigns are no longer taking place. Only routine immunization sessions are taking place. However, because of the lockdown, those routine immunization sessions are not taking place. So our community volunteers, who are a cadre of healthcare workers, mothers between the ages of 25 and 40 that we've trained on strategic behavioral team communication, we train them and they are able to go house to house and provide messages around the importance of personal hygiene, hand washing, social distancing. And so the CSOs that we've trained in those communities where we work have been able to bridge the gap in terms of knowledge and awareness, which the health system is not able to provide because they are living in those communities as volunteers. They're able to go house to house and provide knowledge and awareness raising activities around COVID, and not just only around COVID, around nutrition, as well as around other what we call key household practices. So it is a kind of successful story in terms of ensuring that there's integration of messaging. And we also are able to support tracking of suspected cases of COVID. We're also able to support distribution of hand sanitizers. Yes, we have security issues, especially in areas like Borno. We work in 5 states in Nigeria. 2 are in the northeast, 3 are in the northwest. Borno is in the northeast. Borno is where you have a lot of insurgency like Boko Haram. And so our volunteers, the women that we've trained, are able to innovatively work in those areas through liaison or working together with security agencies to know the times when it's safe to conduct their house-to-house activities to raise awareness. We also realize that working with religious and traditional institutions is very critical, especially because there are a lot of religious myths and misconceptions around COVID, and there are also a lot of religious myths and misconceptions around immunization itself. And so because of the integrated nature of the messages that our community volunteers carry out, they are able to also integrate messages that will address a lot of those myths and misconceptions. What are some of the key challenges that we've seen in Nigeria since the advent of COVID? Logistics of sample movement is difficult and expensive. We have unavailability of kits. We don't have ventilators. We have only about 500 in the country of 200 million. A lot of people in Nigeria, a lot of mothers and caregivers at the community level, at the grassroots, have myths and misconceptions about COVID. They believe it's a disease of the rich. It's only those that travel out of Nigeria that have COVID. And so those are some of the challenges we have. Like was mentioned by past speakers, we also have restriction of movement. And so these are some of the issues that we have to deal with. And what we do is that because our volunteers are from those communities where they live, restriction of vehicular movement do not really affect them. And they know them in those communities, so they are able to walk from house to house, provide those messages and address those myths and misconceptions that they have to deal with. IEC materials are also difficult to find, COVID specific. Another challenge is that even if you have the IEC materials, they are unable to read them because they are in English, and in those communities where we work, most of those parents and caregivers in those populations are illiterate, so they cannot read. So what we're doing is to translate those IEC materials on COVID to local languages like Hausa, like Fulani, like Kanuri, and with that, our volunteers are able to address myths and misconceptions in the local language using those IEC materials. And of course, our volunteers in those house-to-house interactions maintain social distancing, minimum of 2 feet apart. Sometimes they don't even go into their households because they have to ask, is there anybody who has a respiratory symptom in this house? Is there anybody coughing? Is there anybody who has any form of fever? And also, they're also able to teach the household owners the importance of washing your hands regularly and using of hand sanitizer. One of the major challenges we've also seen is inadequate knowledge management. It's a big challenge because For instance, now that there is no movement, lockdown, how do you manage knowledge? And that is where the issue of using technology also comes in. In CGPP, we have smartphones which our volunteers use. And those smartphones, we use them to also disseminate messages offline with Bluetooth, also disseminate messages using WhatsApp, also disseminate messages using local folk stories that depict important ways of avoiding diseases that are transmissible, diseases like COVID. And some of the things we're also doing, we're doing advocacy to donors and partners through multiple platforms. CGPP is a member of the Task Force on COVID, and so we use that platform, of course, to conduct advocacy to other partners to understand the needs on ground, to ensure that resources are put into the COVID response. We have also understood and realized the importance of integrating our data platforms. We have the ODK mounted on the smartphones, and so we use that not only for polio, we are going to use that for COVID reporting as well. Our community volunteers do a lot of engagement around risk communication, addressing myths and misconceptions using local languages. They do a lot of myth busting, that is, sessions that are targeted to addressing particular myths and misconceptions around COVID.
Thanks very much, Usman. We have about 1 minute.
Yeah, this is just a slide that is showing one of our volunteers sensitizing caregivers about coughing into the elbow. This is one of our volunteer community mobilizers teaching illiterate women in a local community where we work on the importance of coughing into the elbow, which is a means of protecting them from contracting coronavirus. This is another picture. Here you see sensitization going on COVID prior to a routine immunization session in the health facility. Here you also see, this is actually one of the insecure areas of Nigeria where we work in the Northeast. This is also one of our volunteers taking these caregivers through frequently asked questions, which we have been able to translate to the local Hausa language. In a nutshell, this is what I want to present in terms of what we're doing in Nigeria. You can see this picture again depicting social distancing. This is some of our volunteers going in for a training. And you can see this local contraption for hand washing. It's just to show what we are doing using locally available resources. Thank you. Over.
It's a great presentation, Dr. Usman. Thank you very, very much for sharing, and for the photos really illustrate the work that you're doing. It's been great. At this point, we'd like to thank all of our presenters and open up the floor for questions. One thing that's been coming up quite a bit in the chat box and sort of on side conversations is the availability of PPE in your countries. I wonder if the panelists can speak to any issues related to PPE, and we'll also, as you're sharing, we will present the poll results here as well. But first, I'd like to pose that question regarding PPE, everything from ventilators to even homemade masks. What is your experience with the availability of PPE? And if people want to respond to that in the chat box, that would be great too. So I'll ask you first, Rebecca, if you can respond to that.
Just a little bit, and I think that actually Gavi would be very well placed as well to respond, because I know that Gavi is working very actively in this area and could give a much more complete picture than I can. The one thing I would just mention that is in Malawi, initially there were problems with, we were hearing that there were problems with the distribution, the availability and the distribution of PPE, such that for a short period, immunization services were actually actually shut down. They were discontinued because of that lack of PPE. Within a fairly short period, PPE was being distributed. But, I guess one other thing I would just want to mention is that for any kind of equipment, it's only as effective as the use of it. And so as we think about personal protective equipment, we also have to think about what kind of training and orientation goes along with it, and what circumstances make it possible to actually use it. I mean, again, we're hearing that health workers in peripheral health facilities may know that they're supposed to be washing their hands, but their ability to actually do so is limited by not having running water in their facilities. Yeah, so I'll just leave it at that. It's something that we're looking into, but we also realize that it is a health system-wide issue, not specific to immunization alone.
Yep, right. Thank you. And Dr. Usman, can you respond a little bit about your experiences with respect to PPE in your work in Nigeria?
Yes, thank you, Sarah. Personal protective equipment in Nigeria is very scarce. We don't have resources for PPEs, and indeed, our government has been doing a lot to see how they could provide PPEs, but it is still a challenge. So what we are currently doing is basically using available cloth to make the cloth face masks. The surgical face masks basically are not allocated only to healthcare workers, and even that is also scarce as well. So it is a challenge, but we were lucky to get some PPEs from Jack Ma Foundation from China. That is what the government of Nigeria has been able to leverage. So it is a challenge, and then we are being forced to innovate by using cloth masks. So that is my experience. Over.
Thanks, Usman. And Camila and Rosanna, can you share your experiences with respect to PPE in Brazil? Are there issues with access there?
Hi. Yes, here in Brazil, there's also a lack of PPE. The government is trying to work on that. Regarding to our partners, I know they own the hospitals that they work. They also have an issue regarding that. So everyone is being creative on, like, people are making masks at home to use in their personal use, to try to leave the surgical masks to use at the hospital. Rosanna, do you want to put another information regarding this? Rosanna, I'm sorry, I'm going to translate. Rosanna, você tem informação adicional referente ao uso de material, equipamento de máscara, luvas, para estar falando sobre a situação aqui no Brasil? Lá no hospital onde você trabalha?
Sim. Nós estamos num momento muito delicado em função da saúde pública no Brasil já vinha passando por uma crise anterior. E o governo federal tem se empenhado, temos tido parcerias com iniciativas privadas também, tentando auxiliar para conseguir mais EPIs para os profissionais que estão na linha de frente, né, trabalhando com Covid. Mas ainda temos algumas dificuldades. Não falta completamente, mas ainda temos algumas limitações. Quantitativo de profissionais e de EPIs, de leitos também disponíveis.
Calma aí, deixa eu traduzir. So she's been saying the challenges that her hospital is also facing regarding this. She was mentioned that the federal government is working really hard. They're trying partnerships with companies, even international companies, to find these materials. Moment at the hospital where she works, they still have some materials, but they're in the short supply.
Great. Thank you very much for being able to respond to that. We'll take another question. looking at going back to this question related to the integration of nutrition and delivery of food services. So, do the panelists have experiences with integrating food delivery along with the immunization?
This is Rebecca Fields. I'd say that typically for immunization, the intersection with nutrition is, at least for routine immunization, is typically that growth monitoring and promotion occurs during the same contact, excuse me, as immunization. And also vitamin A supplementation is often given at 9 months of age during the measles contact, and now increasingly with measles second dose of measles vaccine introduced at about 18 months of age. That's the time for another dosing with vitamin A. Those are sort of classically how immunization and nutrition intersect. Not so much on delivery of food supplementation.
If I could just come in, Sarah?
Mm-hmm. Yep.
Yeah, in Nigeria, we train our VCMs on the preparation of ready-to-use therapeutic food. We have a local version we call Gavi-eligible. It is made from granite-based paste. You add crayfish and some other locally available food. So we teach our volunteers how to prepare this nutrient-rich diet using locally available food. And they go to households and they teach the mothers and caregivers how to use locally available food to prepare this nutrient-dense diet to provide for children who are malnourished. And that has recorded success in places like Kano in northwest Nigeria, where malnutrition is an issue. The emphasis is on training mothers and caregivers to use locally available food to prepare nutrient-dense diet in those areas where poverty levels are very, very high. In terms of food distribution, our volunteers in Borno State in northeast Nigeria work in collaboration with Action Against Hunger to distribute food items to internally displaced persons in IDP camps in specific locations in Borno. That has worked very, very well, and that has served like a kind of best practice because it is a package of service. Our VCMs, our volunteers provide knowledge and awareness around immunization and also provide the IDPs with food that comes from Action Against Hunger. Over.
Thanks, Usman, and thanks everyone for joining.
Hello, good afternoon. Hello. Hello,
Yep.
good afternoon.
Hi.
Are you getting me? Yeah, sorry for coming in. I find it difficult in joining the meeting. Abdul Kid and the Waiswari from Children Advocacy Forum, the Executive Director, and from Sierra Leone. Sorry, once more for joining you guys late. If I may just come in some of the key things that were discussed. I just meet this guy from Nigeria doing the presentation. What I
hello.
gathered. Hello.
Oh, hello. Hi. We're just in the process of closing the call and thanking our speakers. Could you put any questions in the chat box, please, and we will capture them. This is Julie Dargis from Core Group, and we're so pleased that you were all with us. We're sorry we went a couple of minutes over. Thanks to those that stayed with us for the 2 minutes. I just want to remind you that we have in the chat box where you can get the resources from our website. Thank you to Ms. and the Gavi team for your great participation. Rosanna and Camila represent Smile Train, Rebecca Fields from JSI, and Dr. Samuel Usman from our Core Group Partnership Project in Nigeria. We've really appreciated your presentation. We are capturing all your questions, and as people are logging off again, thank you for those that stayed the extra minute. The call is now officially closed, and we wish you all a wonderful day and stay safe. Have a great weekend. Goodbye.
Thanks.
Thank you.
Bye.
Thank you. Bye-bye.